call Professor Differenzo. He's always ready. We will postpone the discussion till the end.
Yes.
I think, Prof, you will talk about pathophysiology of type 2 diabetes mellitus, right?
I will.
Thank you very much. 20 minutes.
So, unlike our preceding professor, this professor does not believe on being on time, which is typical for Italian time. In fact, I learned that my first visit to Italy, that it actually was a disgrace to be on time. So I actually have adhered to that goal, and will also do so today. Okay, if I can make this. Yeah. How about putting the first slide on for me?
I will try myself. What is your topic? Which one?
That's your job.
My goodness. Nancy?
Mohammed, are you there?
Where? And Galaxy? بتاع جالكسي مؤتمر طبي. Press conference. Well, we are reaching rapidly. I think the smartphones and gestational diabetes will need an IT department, right? Or it can be done without it. So I'm just trying to, that's it. Surgeons are good in these things, Nancy. But you are letting us do things without a knife, which is difficult.
So the other caveat that I didn't tell you is that I actually do not own a computer, and I've never touched the on-off button to a computer. And as long as this computer still works, I hopefully will continue along those lines. So I am going to talk about the pathophysiology. To do this in 20 minutes is impossible, but I'll try to do it in 30 minutes. So when I gave the Lilly lecture, our understanding of what caused type 2 diabetes was really pretty simple, and I entitled it the triumvirate. So we know from studies that we and others have carried out that this disease starts with insulin resistance. This is the earliest detectable abnormality. The insulin resistance involves both the liver and the muscle. But early in the natural history of the disease, your beta cells are able to read the severity of the insulin resistance, and your beta cells will secrete a sufficient amount of insulin to offset this defect in insulin action. However, with time, your beta cells can't continue to release this robust amount of insulin, and as your beta cells start to fail, the first thing you see is the insulin resistance in liver become manifest by an overproduction of glucose throughout the sleeping hours. So when the diabetic wakes up in the morning and they have an elevated fasting glucose, it's for something that started 10 or 12 hours before. And if you start with an elevated fasting glucose, you're always playing catch up and you're never going to get this person controlled. Then the diabetic, when they get up in the morning and they have their breakfast and then followed by the lunch and the dinner, the carbohydrate that's in the meal has to be taken up and disposed of in the muscle. But now because the muscle is resistant to insulin, you get postprandial hyperglycemia. And as I said, in 1987, this was a very simple understanding of what caused type 2 diabetes. But in the last 15 or 20 years, we've come to understand there are two major sort of advances. One has to do with the beta cell, we'll go into in more detail, and that is the beta cell failure occurs much earlier in the natural history of type 2 diabetes, and is much, much more severe than we previously anticipated. And when I talk about treatment this afternoon, it'll become very clear that if you have drugs that don't correct the beta cell failure, you are going to get progressive hyperglycemia. The other aspect of the disease that we've come to learn is very complicated with multiple pathophysiologic disturbances. So let's first take a look at this beta cell failure story, because this is really critically important. You, in your practice, cannot measure beta cell function. It's not possible. But the surrogate measure for beta cell function is the A1C. If the A1C is rising, by definition, that means your beta cells are failing and the medication that you're using are the wrong medication, or the dose is insufficient. So how do we know this? We know this from two very large studies that we carried out in San Antonio. One is the San Antonio Metabolism Study, the other is the Vegas study. There were 259 people with prediabetes, IGT, over 200 diabetics, and you can see a large number of control subjects. Everybody had an oral glucose tolerance test, and then on a separate day they came back for an insulin clamp, or we infuse insulin to measure insulin sensitivity. This is the gold standard for evaluating insulin resistance. So, to the left, what I'm going to show you are the glucose area under the curve, and to the right, the insulin area under the curve. Starting with the control subjects, don't worry about units. So what I would like you to do is just compare the heights of the bar to the control subjects as the heights of the bars come up. Here are the people with impaired glucose tolerance, and I've broken them into 3 equal tertiles. 140 to 160, 160 to 180, 180 to 200. And with glucose, you can see there's a progressive rise in glucose with increasing tertiles. For insulin, however, you see something that's really quite different. For insulin, and I don't know if this works here.
I think the second button.
Second button. That's on the computer. Oh, okay, I got you. Yeah. But it's not very bright, so I'll just talk to it. For insulin, you can see that it's a very, very different profile. Initially, there's an increase in insulin release, but then with time, the insulin level starts to decline. Now, if you simply looked at the insulin levels, you would think that the plasma insulin response in the beta cell is quite healthy because the insulin level is increased. But in fact, what you're going to see is, despite the elevated insulin level, beta cell function, which cannot be assessed by measuring the insulin level, is markedly impaired. And then if you continue to follow these people, you see with time, and I've taken the diabetic group and now divided them into 4 equal tertiles. With worsening diabetes, there's a progressive decline in the insulin response. And in 1987, I referred to this as the Starling's curve of the beta cell, because it looks like Starling's curve of the heart. Now, what is the gold standard for beta cell function, which none of you can really measure in your office? That's why I made the point that it's critically important that you look at the A1C, okay? So the gold standard is during the OGDT, there's an increment in glucose. And then in response to the increment in glucose, there's an increment in insulin. But in addition, the beta cell can read the severity of the insulin resistance. So the gold standard is plotted here on the y-axis, increment in insulin per increment in glucose, all factored by how insulin resistant you are. So let's start with the people with normal glucose tolerance. So the first point on this curve is individuals who I give a glucose load to. Their blood sugar goes up, and then the 2-hour value is less than 100. That's as good as your glucose tolerance is ever going to be. And then, if you look at the people who have a 2-hour value at 100 to 120 or 120 to 140, you can see that within the normal range of, quote, glucose tolerance, according to the American Diabetes Association, you already lost 50% of your beta cell function. So this disease starts long before the current criteria that you're used to seeing for diagnosis of prediabetes and diabetes. So here are the people with IGT. If you look at the people in the upper tertile of IGT with a 2-hour value 180 to 200, these people have already lost 90% of their beta cell function. And I'm not going to show you the data with the insulin clamp, but they're already maximally insulin resistant. So if I told you I had someone that was maximally insulin resistant and they lost 80% of their beta cell function, and I asked, what's wrong with this person? This person has diabetes from the pathophysiologic standpoint, but of course not by our current diagnostic criteria. And now if I put up the diabetics and I've divided them into 6 equal groups, you don't have to lose much more beta cell function to go from a 2-hour glucose of say 180 or 190, which is not too bad, to a 2-hour glucose is greater than 300. Now, in everyday life, things don't happen in absolute terms. They happen as a log function. So on this slide, what I've done is taken the log on the y-axis of beta cell function and plotted it against the log of the 2-hour glucose. And you can see this becomes completely linear with a correlation coefficient of 0.91. You virtually never see this kind of correlation in any human disease. So this is reality, okay? And what it's saying is once you're maximally insulin resistant, what happens in terms of your glucose tolerance is totally determined by your beta cell function. And that's why having drugs that work on the beta cell, in addition to insulin sensitizing drugs, are critical. Now, you can very easily, on this slide, depict who are the people with NGT, who are the people with IGT, and who are the diabetics, because I color-coded them. But what would happen if I took the color away? And you see I'm a magician. Now, go up there, and if I asked you, where would you put the line for NGT and IGT and diabetes, you would be very hard-pressed to put a line up there, okay? Because this is a continuum. And it's really a mistake to think all of a sudden you have normal glucose tolerance and the next day you wake up and you have IGT or diabetes. This happens over many years. And the implications for treatment are very important because it says the earlier you start, the better off you're going to be in terms of preventing this disease. So people with IGT, they're already maximally or near maximally insulin resistant. They've lost some 80 to 90% of their beta cell function. And this is the real concern. They've lost a significant amount of beta cell mass, and that you need to stop. And they already have the microvascular complications. So diabetic retinopathy, neuropathy, albuminuria is present in 10 to 20% of these individuals. Now, let's take a closer look at what is responsible for the decline in beta cell function. Well, number one at the top, none of us like. This is called aging. And my first grant from the National Institutes of Health was from the gerontology section. And what we showed is that as we get older, with each decade of life, is a progressive decline in beta cell function. We also know that genetics are very important. The first gene linked to beta cell failure was the TCF7LT2 gene, actually, and that was described in San Antonio by Michael Stern. And what's interesting is that almost all of the genes that have been linked to type 2 diabetes are transcription factors at the level of the beta cell. There are actually only 2 insulin-resistant genes that have been described. There are a whole host of beta cell genes. Insulin resistance, a big problem. What's driving the epidemic of diabetes is the epidemic of obesity. You gain weight, you become insulin resistant. You become insulin resistant, that puts a big stress on your beta cell, and you get progressive beta cell failure. We also know that obesity is synonymous with lipotoxicity. When you're obese, not only you develop, put fat in the fat cells, but as Dr. Abdulghani told you yesterday, once you fill up the fat cells, it starts spilling out. In the muscle, it causes insulin resistance, the excess fat in the beta cell impairs beta cell function. Glucotoxicity, another important concept that we developed many years ago. High glucose cannot start the disease, but once the glucose becomes elevated, the high glucose feeds back to cause progressive beta cell failure. When you secrete insulin, you secrete insulin in the 1-to-1 ratio with amylin. Because you're hypersecreting amyloid, and this has to be removed by the endoplasmic reticulum. And you overload the endoplasmic reticulum, and what you get is buildup of degradation products of amylin, which are very toxic to your beta cell. We also know that your beta cells have become resistant to the effect of both GLP-1 and GIP. So you can see there's a whole host of factors that are predisposing to beta cell failure. But the one that you really need to be careful about is the decrease in beta cell mass, okay? So this is a study that was carried out by Dr. Peter Butler many years ago, and Dr. Butler had approval from his institution, IRB, to collect the pancreases of people who passed away. And of course, he can't wake these people up and do an OGTT, but he had the fasting glucose, and so he characterized them based as having normal glucose tolerance or impaired glucose tolerance on the fasting glucose. And then using very sophisticated techniques, he measured the beta cell volume. And you can see, even at this pre-diabetic state, there's a significant decrease in beta cell volume. Volume is not exactly equivalent to mass, but for practical purposes, you can put them as parallel to each other. And then, if you look at people with type 2 diabetes, there's a further decrease in beta cell mass. Now, later this afternoon, I'm going to show you how to completely restore beta cell function. There is nothing in the human body, there is no drug that I'm aware of that's going to increase beta cell mass. So the longer you wait to treat, and the longer you lose beta cells, now you're in trouble. And that is why I'm a big advocate of starting earlier with multiple therapies that will preserve your beta cell function. So now let's turn to the other side of the loop. What about the insulin sensitive tissues? And let's start with the muscle. So these are the original data with the insulin clamp in which we measured insulin sensitivity in healthy control subjects, the height of the bar in yellow, in normal weight type 2 diabetics, which are very difficult to define, in green. And you can see that the normal weight diabetics are severely insulin resistant. They metabolize in response to insulin about half the amount of glucose. And then in the far bar are obese people who have normal glucose tolerance. Obese people are as insulin resistant as type 2 diabetics. And so the worst thing that can happen in a type 2 diabetic is to gain weight. Then they get a little bit more insulin resistant, and that beta cells are already dysfunctional. They can't handle the increase in insulin resistance. Now, where is this insulin resistance? So when we did these early studies, we carried them out with catheters in the hepatic vein, femoral vein, actually jugular vein, and what we showed is the major site of the insulin resistance during the insulin clamp was in muscle. So when you start the insulin clamp in healthy control subjects shown in yellow, you can see within the first 40 minutes there's a major increase in glucose uptake, and then at about 60 minutes it reaches a plateau. If you look in the diabetics who are shown in orange, you can see there's about a 40-minute delay before insulin starts to stimulate leg muscle glucose uptake. Now, eventually, you start to increase glucose uptake in the muscle, but even if you wait and carry out the study of insulin infusion for an extra 60 minutes, you can see that you never catch up. The diabetic muscle is severely insulin resistant. Now, why is the muscle resistant to insulin? So, everything that I'm going to tell you has been published in multiple studies, but I'm just going to summarize it for time. So we know that there are two major pathways in muscle where the glucose goes. One is in glycogen. About 2/3 of the glucose goes to glycogen, 1/3 of the glucose is oxidized. And there are major defects in both of these pathways. Why? There's a major defect in glycogen synthase, which we've shown in muscle biopsies. There's also a major defect in pyruvate dehydrogenase. But if you go even further back upstream, the ability of insulin to activate hexokinase 2 and increase the message in protein for hexokinase 2 is markedly impaired. But you can take this a further step backwards, and we and others have shown that there's a major defect in the glucose transport system. But even before that, and Dr. Abdelghani showed you these data yesterday, there's a major defect in the insulin signaling pathway. So in order for insulin to work, it must bind to its receptor, and it needs to send a signal over to the glucose transport system. Now, how does that happen? So there are a number of substrates that are involved in this. IRS1, after you tyrosine phosphorylate the insulin receptor, that leads to tyrosine phosphorylation of IRS1. You activate PI3 kinase AKT, and insulin moves into the cell. So what goes wrong in a person with type 2 diabetes and obesity? Actually, tyrosine phosphorylation of the insulin receptor is perfectly intact. The defect, as I'm going to show you, is after the insulin receptor. But what people, I think, forget is that in addition to glucose metabolism, insulin in this insulin signaling pathway plays a critical role in endothelial function. And so once you activate this pathway, this is the pathway that activates nitric oxide synthase. This generates nitric oxide. Nitric oxide is the most powerful vasodilator in the human body. It's also the most potent anti-atherogenic molecule in the human body. So what goes wrong in a person with type 2 diabetes? There's a defect at the level of IRS1. You cannot tyrosine phosphorylate IRS1. This is both genetic and also in a major part related to lipotoxicity. Now, if you cannot activate IRS1 in the signaling pathway, glucose does not get into the cell, and you knock out nitric oxide synthase, you knock out nitric oxide. And that is why diabetes and cardiovascular disease go hand in hand. And as Dr. Abdul-Ghani showed you yesterday, the ticking clock for atherosclerosis starts when you're born. The ticking clock for diabetes complications starts when your glucose goes up. So it's not uncommon that when you see a newly diagnosed diabetic, they already have advanced cardiovascular disease. Now, what about the liver? And so we also showed using tracers, and these are actually the first tracer studies ever carried out in humans, that there's a significant increase in the basal rate of hepatic glucose production. So when you go to sleep at night, your liver is resistant to insulin, your insulin levels are dropping, and what you can see in the diabetics in orange, that there's a significant increase in the basal rate of hepatic glucose production. And the difference from the controls, if you look at the units, may not seem very big. It's 0.5 milligram per kilogram body weight per minute. But if you multiply that times 100 kilogram person, 40 minutes during the day, you're talking about an extra 50 to 75 grams of glucose being dumped into the systemic circulation every night throughout the sleeping hours. And this is the major reason why diabetics wake up in the morning and they have an elevated fasting glucose concentration. And if you were to plot now on the x-axis, the fasting glucose, against hepatic glucose production on the y-axis, the controls all cluster with a rate of hepatic glucose production of 2 and a fasting glucose of about 90. And the diabetics, or the individual orange dots, you can see that as hepatic glucose production goes up, so goes up the fasting glucose, and again with the correlation coefficient, it's approaching 0.9. This study has been repeated 101 times in the literature with the exact same result 101 times. So this is a universal truth. Now, what's the other problem in people with type 2 diabetes? This is not a simple disease. So the core defects are still there. In the upper left, beta cell failure. In the bottom, hepatic insulin resistance. And then at the bottom right, muscle insulin resistance. But I think most of you have heard of the ominous octet, was the title of the Banting lecture that I gave, From the Triumvirate to the Ominous Octet, a new paradigm for the treatment of type 2 diabetes. So there are 5 other defects that we have to deal with. So what are the 5 other defects? Well, let's start with number 4. This is what I call the harmonious quartet. But it's singing a very, very bad tune for the diabetic. So all diabetics have elevated plasma FFA levels. Elevated FFA levels, and again, there's an enormous amount of publications that go behind this. I'm just simplifying this for you. Elevated FFA are very toxic to your beta cell. Elevated FFA drive gluconeogenesis and hepatic glucose production, and elevated FFA cause insulin resistance in a muscle. What's number 5? The quintessential quintet. This is the incretin defect. So when you ingest a meal, you release 2 incretin hormones, GLP-1 and GIP. And it turns out that your beta cell, as well as your alpha cell, are severely resistant to both GLP-1 and GIP. So this leads to a major defect in insulin secretion and elevated glucagon levels, which drive endogenous hepatic glucose production. So this is a very nice demonstration at this point from a group in Denmark, where to the left, what they did is they infused GLP-1 and then measured the insulin response in control subjects, and you can see in yellow a nice increase in insulin secretion. And the diabetics in orange, absolutely no increase in insulin secretion whatsoever. Severe resistance to GLP-1. Now, if you take the diabetics back to the right, and now you increase the dose of GLP-1, you get a perfectly normal response. And in fact, this is exactly what we do in treating our patients. GLP-1 receptor agonist, and we'll talk about treatment. This is one of my first-line drugs. Cetaceous sextet. So what does cetaceous mean? It's like a thorn. It's like something sticking into your body that hurts, okay? And this is the alpha cell dysfunction. So this was originally described by Roger Unger in Dallas. Diabetic patients have elevated glucagon levels, which fail to suppress in response to a meal, and the elevated glucagon levels drive endogenous hepatic glucose production. So this is a very nice study by Dr. Barone, where they measured hepatic glucose production in the diabetics in orange, in the control subjects in yellow to the left, and to the right, you can see the plasma glucagon levels elevated in the diabetic subjects. And then what they did is they infused somatostatin and replaced insulin, but not glucagon. So they knocked out the glucagon levels, and when they did this, you can see the glucagon levels came to normal and a marked decrease in hepatic glucose production, a very nice demonstration of the pathogenic role of elevated glucagon levels. Next, we have the kidney. So what's the problem at the level of the kidney? And so let me just briefly review with you how the kidney handles glucose. So every day of our life, we filter about 180 liters of fluid with a glucose of about 100 milligrams per deciliter. You filter 180 grams of glucose. And you can see in the bottom right, no glucose appears in the urine. So how does this happen? 90% of the glucose is reabsorbed in the SGLT2 inhibitor, and the other 10% in the SGLT1 inhibitor. Well, it turns out in the diabetic, there's marked alterations in the activity of these transporters. And the net result is a great distortion in what happens in terms of the threshold for dumping glucose into the urine. So these are studies that Dr. Abdulghani and I did many years ago. And what I'm going to plot for you here on the x-axis is the glucose concentration, and then on the y-axis, the amount of glucose that's either reabsorbed or excreted. This is what's called the glucose titration curve. I plug in an IV, I infuse glucose, and I raise your blood sugar. And as I go from 100 up to 200, no glucose appears in the urine. You see that line is flat, parallel the x-axis. But when I get to 200, this is the yellow line, I've now exceeded the threshold, and now glucose excretion goes up. Glucose absorption, of course, is the mirror image. That's the orange curve. So glucose reabsorption increases linearly up to about 200, and then it plateaus. So what goes wrong in the diabetic? The threshold that's spilling glucose in the urine goes up dramatically. But what's most disturbing is the increase in the threshold is directly proportional to the hemoglobin A1C. So when your A1C is 6.5, the threshold is already increased. When the A1C gets to 7.5 to 8.5, the threshold now goes up to 240 to 250 to 280. So now instead of dumping glucose in the urine and escaping and allowing the blood sugar to go down, you're enhancing the reabsorption of glucose. And we have drugs that will block the SGLT2 transporter and lower that threshold. And then the last of the ominous octet is what happens in the brain. And this has to do with insulin resistance and other defects in terms of appetite regulation. There's also an ominous octet for what goes wrong in the brain. I'm not going to take you through that, but we can talk about it later. But these were the original studies using bold MRI to look at hypothalamic function that were carried out by Dr. Matsuda when he was a fellow with us. And when we gave people an oral glucose load and the insulin level goes up, in the lower posterior hypothalamus, where most of this appetite regulation goes on, if you look at the activity in that area, the ability to excite the neurons, which are involved in shutting off your appetite, is markedly impaired. And the time to activate those neurons is also markedly impaired. So there's a major defect in terms of the regulation of appetite. There are many hormones that are involved in this, and I'm not going to take you through all of this, but I think everybody in this room understands that what's driving this epidemic of diabetes is the epidemic of obesity. Now, if you ask me, and I have 3 slides that I'm going to finish with, what would I add to the ominous octet? I would add inflammation. So if you come up with something that rhymes with inflammation, it's the noxus non-tuplet. So what is a non-tuplet? That's a woman who delivers 9 babies. Heaven bid for her. It's a very painful experience, okay? So there are a whole host of inflammatory markers that have been involved here. At the top of the list, I would put the I-kappa beta, NF-kappa beta system, and the toll-like receptor 4 pathway. We've done a lot of work on this, and there are many other people who have shown their major abnormalities here. And the MAP kinase pathway, metalloproteinases, AMP kinase, the TNF-alpha system, all of these inflammatory pathways are all overactive in the diabetic, and they're all associated with severe insulin resistance. The other number 10 on the list that I would say is well established, the decadent decouplet, is vascular insulin resistance. So in the muscle capillaries, there are 2 out of the 3 capillaries in the muscle bed are not open. So most of the capillaries are closed. And when I give you insulin, and insulin is a powerful vasodilator, from going from rest to with insulin, now I activate these other capillaries. I vasodilate them. So now I have more perfusion of the muscle, and I'm bringing more insulin to the muscle. So what goes wrong in a person with diabetes? There is severe vascular resistance, and the ability to cause vasodilation is impaired. And I would for sure say that we can add these 2 to the ominous octet, make a decadent decouplet. Now, I know someone's going to ask me in the question and answer period, and this is the last slide, so I put it up, is the microbiome. And I'm, at this point, agnostic. And my opinion, I haven't seen any data in humans that convinces me that the microbiome plays an important role in the development of type 2 diabetes. Now, someday, I think maybe some data will come out. I'm not sure it's going to convince me. It may convince me it's not playing a role, or it may convince me that it is playing a role. But of course, it's a very hot and controversial topic, so I at least wanted to mention it. It's something that you're going to have to wait and see what happens in the future. Thank you very much for your attention.
Thank you very much, Prof.